Cardiopulmonary stress test, C, principles, methodology, and clinical insights. Welcome everyone. Today we're exploring the cardiopulmonary stress test, a cutting-edge diagnostic tool that assesses the integrated response of the cardiovascular, pulmonary, and musculoskeletal systems during exercise. Unlike traditional stress tests that focus solely on cardiac function, CPET provides a holistic view, helping us identify the causes of exercise intolerance and guide patient care. Introduction. The cardiopulmonary stress test is indispensable for evaluating unexplained symptoms such as dyspnea and fatigue. By differentiating between cardiac, pulmonary, and muscular causes, it helps us diagnose conditions like heart failure and pulmonary hypertension, assess preoperative risk, prescribe exercise regimens, and monitor treatment efficacy. Its applications are wide-ranging and play a critical role in personalized medicine. Indications. CPET is particularly valuable in the following scenarios. Unexplained dyspnea or fatigue, to distinguish cardiac, pulmonary, or muscular origins. Heart failure evaluation, to determine the severity and prognosis. Pulmonary hypertension, for diagnostic and prognostic purposes. Preoperative risk assessment, to predict surgical outcomes, especially in high-risk patients. Exercise prescription and rehabilitation, to tailor programs for patients with chronic conditions. Monitoring treatment response, to assess the effectiveness of therapies in conditions like COPD or heart failure. CPET's ability to address these indications makes it a cornerstone in modern cardiopulmonary diagnostics and management. How CPET works. CPET is conducted using a treadmill or cycle ergometer, with the cycle ergometer being more commonly used. During the test, patients wear a mask or mouthpiece for gas exchange analysis, and their heart rate, ECG, blood pressure, and oxygen saturation are continuously monitored. The test involves a gradual increase in workload, allowing us to measure oxygen uptake, VO2, carbon dioxide production, VCO2, and minute ventilation, VE, in real time. Physiological parameters measured. This detailed assessment provides key physiological metrics. VO2 max, the maximum oxygen uptake, reflects aerobic fitness and cardiac output. The anaerobic threshold marks the shift to anaerobic metabolism and indicates exercise efficiency. The VE/VCO2 slope reveals ventilatory efficiency, often pointing to conditions like heart failure or pulmonary hypertension when elevated. Breathing reserve highlights potential ventilatory limitations, such as in chronic obstructive pulmonary disease, COPD. Procedure. The CPET procedure begins with baseline measurements taken at rest. Patients then undergo an incremental exercise protocol where the workload increases every 1 to 3 minutes until they reach peak effort or experience limiting symptoms. Finally, the recovery phase provides additional data as physiological parameters return to baseline. This structured approach ensures we capture comprehensive information about the patient's exercise response. Key results and their interpretation. CPET results are rich with insights. A reduced VO2 max might suggest cardiac dysfunction, pulmonary disease, or deconditioning. A delayed anaerobic threshold indicates diminished aerobic capacity. An elevated VE/VCO2 slope points to ventilatory inefficiency, and a low breathing reserve indicates pulmonary limitations. Each of these findings helps us pinpoint the root cause of a patient's symptoms, offering clarity in complex cases. Common findings. When interpreting CPET, it's important to recognize common patterns. Cardiac limitations may show a flattened VO2 curve and reduced heart rate reserve. Pulmonary limitations typically involve low breathing reserves or oxygen desaturation during exercise. Deconditioning often presents with a low VO2 max, but normal anaerobic threshold and ventilatory efficiency. These distinct patterns guide accurate diagnoses and tailor interventions. Strengths and limitations. CPET's strengths lie in its ability to provide integrative, objective data that inform diagnosis, prognosis, and therapy. However, it does require specialized equipment and trained personnel, and it may not be suitable for patients unable to exercise adequately. Despite these limitations, CPET's value in managing complex cases is unmatched, offering insights that other tests simply cannot provide. To illustrate its clinical utility, consider the case of a 50-year-old male with unexplained dyspnea on exertion. His CPET revealed a reduced VO2 max an elevated VE/VCO2 slope, and a delayed anaerobic threshold, findings that pointed to heart failure with preserved ejection fraction, HFpEF. These results provided clarity in diagnosis and informed the subsequent treatment approach, demonstrating the practical applications of CPET. Summary. In summary, CPET is an invaluable tool for assessing exercise intolerance, offering a detailed understanding of the interplay between the cardiovascular, pulmonary, and muscular systems. Its applications range from diagnosing and managing chronic conditions to optimizing treatment strategies. By incorporating CPET into clinical practice, we can deliver more precise, patient-centered care.